Namaste, Dr. S. Jayaraman, consultant pulmonologist. Today we are going to discuss about the pleural effusion. Pleural effusion is one of the commonest chest diseases we come across in our practice. Pleural effusion by definition, accumulation of fluid in the pleural cavity. Pleural cavity is a lining membrane of the visceral and parietal pleura. In between the visceral and parietal pleura, the potential space is called as the pleural cavity. Normally, in the pleural cavity, 0.5 ml per kg of fluid, maximum an adult 50 kg man or women will have a 25 to 50 ml of fluid will be there. This is a normal. If abnormal accumulation of fluid collection in the pleural cavity is called as pleural effusion. So, the pleural effusion means accumulation of fluid in the pleural cavity. What are the common reason for the accumulation of pleural effusion? That means mainly there are two entities called one is the transudative pleural effusion. Transudative pleural effusion means in the pleural fluid the protein content and LDH content is less than the 3.5 and less than the 150 milligram. And if the protein content is more than 3.5, we call it as the exudate. So, pleural effusion means in the pleural fluid, protein and LDH, based on the protein and LDH values. So, we are dividing the pleural effusion into transudative pleural effusion, exudative pleural effusion. Transudative pleural effusion means commonly we come across a lot of failures, mainly cardiac failure, congestive heart failure, renal failure, liver cell failure, anemia and respiratory failure. So, these are all failure can cause the transudative pleural effusion. In this effusion, if you do the pleural fluid test, you find out the less than protein value will be the less than 3.5 gram. In other entity called a exudative pleural effusion, the protein will be very high, more than 3.5. What are the reasons for exudative pleural effusion? There are main three reasons. One is the infection, whether is it a simple infection like pneumonia or TB. Other one is the inflammatory conditions like systemic lupus erythematosus, rheumatoid and other inflammatory disease. Third thing is the cancer, malignancy. In malignancy or in a cancer, you will get a high protein level. So, these three is very important cause of exudative pleural effusion. So, first any pleural effusion, the broadly divides into three. Any failure can cause transudative pleural effusion, and infection TB or pneumonia can cause exudative pleural effusion, or malignancy cancer can cause the exudative pleural effusion. So, what are the symptoms of pleural effusion? The main symptoms of pleural effusion is the dry cough and breathlessness, that means breathing difficulty, and mild chest discomfort in the form of chest pain, pleuritic chest pain. So, and sometimes fever, you may get fever, and other symptoms of TB and pneumonia and other symptoms. The main symptom is dry cough or cough with a mild chest discomfort, pain and breathing problem. So, this is an important problem. Any person with these type of a problem, so we have to clinically confirm whether patient has pleural effusion or not. What are the investigation to confirm whether pleural effusion or not? So, for diagnostic purpose, we do a chest radiograph, chest X-ray. Chest X-ray usually shows there is a whiteout, there is a homogeneous opacity, obliterating costophrenic and cardiophrenic angle. And further, you need a ultrasound chest to find out whether fluid is there, whether fluid or solid component. If it is the fluid, the main test to confirm pleural effusion, what is the cause of pleural effusion, why the pleural accumulation of fluid in the pleural cavity. For that, we have to remove the fluid by injecting after local anesthesia under the aseptic precaution to take the fluid and send for the routine testing like bacteriology testing, cytology testing and the culture testing, so and biochemical testing. In the biochemical, routinely we do a protein and LDH. These two are important. Based on the pleural fluid protein LDH, we divide the pleural effusion into transudate or exudate. And ADA, this is a adenosine deaminase. This is a very important marker in the pleural fluid to diagnose the patient has TB or not. In tuberculosis, the ADA level will be high, elevated. Other condition also the ADA level will be high, example malignancy, but TB is one of the first possibility if the ADA level is very high. And the cell count, in the cell count we see whether lymphocyte is predominant or neutrophil is predominant. If it is lymphocyte predominant, there are three diagnoses mainly. One is TB, malignancy, cancer, or the systemic lupus erythematosus and other inflammatory conditions. If it is a neutrophil present predominantly in the pleural fluid, that indicates infection caused by pneumonia, mainly bacteria and other things. So, and we do the culture and AFB smear, gram strain and all to find out any infection in the fluid or not. This way we can diagnose the pleural effusion. And further you have a dilemma whether TB or malignancy, you do not know exactly. ADA level is normal, cell count is lymphocytic, and the cytology report shows there is no malignant cells. That condition, you have to go for the pleural biopsy. Pleural biopsy, there are two ways we can take. One is the blind pleural biopsy using Abraham's needle. Other method, the gold standard method to diagnose the pleural effusion is the thoracoscopic pleural biopsy. The thoracoscope means a small instrument, microscopic instrument under anesthesia will insert into the pleural cavity and visualize the pleural cavity and take the biopsy. This will clinch whether the patient has a TB or malignancy. So, thoracoscopic pleural biopsy is a very important tool to diagnose pleural effusion. What are the indication of thoracoscopic pleural biopsy? Thoracoscopy indicated in a case of undiagnosed pleural effusion. If you think in terms of any malignant pleural effusion, thoracoscopy is indicated, or any recurrent effusion, or any recurrent pneumothorax, or any hemorrhagic effusion, you have to do thoracoscopy and pleural biopsy and clinch the diagnosis of malignancy or TB or inflammatory diseases. So, once you clinch a diagnosis, you have to start the treatment. If it is failure, you have to start the anti-failure treatment, cardiac failure treatment. If it is an infection, like simple infection, you treat with antibiotic, within 3 to 5 days, maximum 7 days, the fluid will go. If the patient has a TB infection causing pleural effusion, we have to give a 6 to 9 months course of anti-TB therapy. It will cure, TB will be cured completely by giving 6 months treatment, 6 to 9 months treatment. If it is a malignancy, we have to give the symptomatic and supportive therapy and chemotherapy, depends upon the pleural staging, again the cancer staging. So, pleural effusion broadly classified in two, that is accumulation of effusion, fluid in the pleural cavity is called pleural effusion. There are two types, transudate, exudate. Transudate, failure, exudate, TB, malignancy and systemic lupus erythematosus, other inflammatory disease. Confirmation by biopsy, gold standard test is thoracoscopy and biopsy. So, we can do pleurodesis. Pleurodesis means to close the pleural space by putting chemicals into the pleural cavity to close the space to prevent a further accumulation of fluid. So, this way we can do the pleural effusion diagnosis and management. Pleural effusion is one of the common clinical presentation in the pulmonology practice. So, pleural fluid analysis are very important. In that, protein, LDH, ADA are very, very important. Cell count, cytology are very important. Biopsy is a gold standard. Thoracoscopy pleural biopsy is a gold standard tool to diagnose whether TB effusion or malignant pleural effusion and treat accordingly. So, pleural effusion is one of the common clinical practice in pulmonology.